Thank you again to the organizers for inviting me to present today. As Isabel mentioned, I will be talking about the lessons learned from HIV that we can apply to hepatitis C in the scale-up of treatment and diagnosis in lower and middle-income countries. With the advent of new DAAs to cure hep C, there is the opportunity to tackle the lack of access in programs in low and middle-income countries that currently lead to high mortality, high cost to the public health systems, and continued transmission. In thinking about how to develop and scale up hep C programs, there is a lot that can be learned from the early days of HIV. If you think about what are some of the initial market shifts that we saw in the early days of HIV, we're seeing some of the similar ones in hepatitis C. First, the development of new hep C treatments that offer a new hope to patients. Second, the release of the first WHO guidelines for hep C diagnosis and treatment. And third, a push by global advocates for greater access to treatment. Some of the barriers and the challenges that face hep C are also those that will look very similar to those that worked in HIV in the early days. There are prohibitive prices for necessary drugs and diagnostics, perceived complexity of diagnostic algorithms and treatment regimens, lack of country-level diagnostic and treatment guidelines, lack of policies, implementation plans, lack of infrastructure for treatment and diagnosis, and difficulties in case finding due to perceived stigma. However, there are still some important differences between hepatitis C and HIV that you must think about in thinking about how to actually apply the lessons learned. First, the hepatitis C drugs offer patients a cure. Chronic disease management is not as necessary for hep C. The economic impact. HIV affecting people in their prime has a high direct economic impact. For hep C, later stage mortality has a slightly less direct economic impact. So for governments to justify their national programs, strong evidence is needed. The location of the burden. In the early days of HIV, there was a significant concentration in lower middle income countries. Now, many of those lower middle income countries have moved up in income categorization. And so when you look at hep C, you see a lot of the burden in middle income countries. This has implications for price negotiations and for donor funding. Also, in thinking about donor priorities, back in the early days of HIV, there were a number of donors that were ready to commit to large-scale programs with large-scale funding. For hep C, it doesn't look at this present time that there are as many donors that are willing to commit to such large-scale programs. So we think that there are 7 key lessons that you can learn from the HIV experience to guide future hep C program development and scale-up. First, support operational technical assistance to accelerate guideline adoption, implementation, and updating. 2, to ensure diagnostic programs and products develop in parallel with treatment. 3, coordinate and align activities to leverage existing infrastructure. 4, promote the rational deployment of diagnostic equipment. 5, encourage the availability of a regulatory pathway for generic drugs and diagnostics. 6, emphasize price reduction to drive greater access. And 7, build national, large-scale access programs early on. So thinking about those in a little bit more detail. WHO normative guidance has always been a key factor to accelerate treatment scale-up. Since algorithmic HIV treatment guidelines has enabled not only rapid scale-up of HIV services, but it has also enabled the standardization of first and second-line regimens and task shifting, and also has simplified drug procurement. However, it's not just as simple as having the global normative guidance. There actually is a tremendous amount of technical assistance that CHI and other partners provide and work with countries in terms of actually adopting those guidelines to country context, thinking through some of the operational barriers. Marrying operational barriers and treatment guidelines is very key. If you don't have the planning for HR and budgetary needs thinking about supply chain systems, thinking about procurement and lab networks, your guidelines are not going to be able to be rolled out as easily or as impactfully. So in thinking about what to do for hepatitis C, remembering technical assistance and having partners there to support that technical assistance early on is very important. Operational planning, sitting down and tackling what to do on day one, what to do if a machine breaks, how does my lab network work, is just as important as having the up-to-date treatment guidelines to ensure patient access. Diagnostic programs historically have lagged behind. In pushing the diagnostics to develop at the same pace as treatment is very important. If you think about rapid tests, for example, rapid tests first appeared in the WHO guidelines in 2002. 3 years later, they got their own much more detailed information. But there are still countries that are lacking QA and QC processes around rapid tests. So bringing all of that systems and bringing all of those policies around at the same time is just as important. Also, innovation in diagnostic products has also lagged behind treatment. Point of care is only really just becoming a reality today for CD4 and soon to be, but not yet really, for viral load. Infant diagnosis. Until the advent of infant diagnosis, a lot of pediatric infections that were lagging, the diagnosis of pediatric infections were lagging behind. So we need to figure out how to bring labs along at the same rate as treatment. Providing TA for lab system strengthening, thinking about what are the lab pieces that need to be in place, figuring out how to incentivize manufacturers to, as they are developing new point-of-care options for HIV, to bring along the point-of-care options for hepatitis C, bring along the DBS, improve the rapid tests, develop the antigen tests that are needed. Third, strong coordination among partners can make programs more cost-effective and sustainable. In the early days of HIV, there were many partners working at many different objectives. Many people rallied behind some of the UNAIDS targets. The targets were great. They allowed for a kind of a rapid movement forward together. But at the same time, they also verticalized HIV in a way that now there are many countries looking at how do we integrate HIV better into our health systems? How do we integrate TB and HIV better together? So it's a double-edged sword there in terms of thinking about how do we rally behind those? How do we get strong partners to work together to have the same message with ministries of health, to have the same message with other partners, to bring the same message with donors. So as we think about hepatitis C, we need to think about who is going to be the global body that's going to rally everybody behind targets, who's going to be and push for the hepatitis C targets that we need to kind of advance at the same rate that we did with HIV. And then, because the funding is likely going to be more constrained for hepatitis C, because the price tag is potentially larger than it was for HIV, how do you integrate hepatitis C programs into existing health systems in a sustainable and cost-effective way? The efficient placement of diagnostic equipment has also been a challenge. In some cases, there has been deployment of equipment before the planning of where to actually put it, before the national labs have their strategic plans in place. So efficient placement of diagnostic equipment, particularly testing platforms, is a challenge that we've seen in HIV that has grown and has gotten better, but is still one that needs to be thought about when we're thinking about hepatitis. As we think about how do you apply this lesson learned to hepatitis, we need to think about how do you use what is already there? How do you use the HIV viral load networks? How do you use the centralized testing networks? How do you use the sample transport? And how do you integrate hepatitis C into that? When thinking about the drugs and thinking about access to generics, one of the key factors in making generics more available and low and lower middle income countries is that there were regulatory pathways. So with the PEPFAR or with the WHO PQ program, that created an option. There was also, with the advent of PEPFAR, an option for the FDA to approve non-US market generics. And so though having multiple regulatory pathways has also greatly improved access to generics. On the diagnostic side, it hasn't been as easy and hasn't been as efficient. The PQ process has existed for the diagnostics, but again, it lagged tremendously, the ARV process. So as we think about hepatitis C generics, we need to think about how do we bring them to market? What is the regulatory pathway? What are the options? How do we figure out how to have multiple options, and how do we get the products out there as fast as possible? On the diagnostic side, again, we need to look for what are ways that countries can best share information so that everybody doesn't have to reinvent the wheel, so that validation of a new test doesn't have to happen multiple times, but rather can we somehow figure out how to collaborate and leverage that information so that if it's done in one country, another country in the same region can use that information to advance or accelerate its validation process. The other side of access to generics is on price reductions. And in HIV, there has been a number of successes in getting low-cost generics to the market. There have been strategies such as volume-based negotiation, pooled procurement, the pressure brought on by global advocates, various legal methods to overcome patent barriers, increased competition amongst generics, bringing more generics manufacturers to the market, have all been very key aspects for how we reduced generic pricing. We need to think about what are the mechanisms that we can use for hepatitis C as well. Many of those same mechanisms we can continue to use to reduce the prices of generics and to bring them to the low and to the middle income markets. Finally, the last lesson learned is definitely one of the most important. In HIV, there were partners in governments that dreamed big. There were partners in governments that said, we're not going to do small pilots, but we're going to go out there aggressively and have a big vision for national large-scale access programs. Those are very important, connecting that to the generic drug pricing. Again, if you're looking for volume-based discounts, having a couple of early adopter countries that are ready to take that leap of faith and ready to say, we can do it, we can get these volumes, knowing that maybe the prices aren't what they need to be right now, but we're going to put together the policies and the guidelines and the plans to send the right market signals so that we can break the cycle of high prices, no demand. And so as we think about Hep C, we need the same. We need a couple of leading countries to take that big leap of faith and to say, yes, we can be the example. We will do large national scale programs that will provide access. We'll think about how do you do demand generation? I think I should have mentioned this even talking about HIV. So as you think about the wide scale programs, having demand generation, having multiple entry points, having community activists bring in people for testing, sensitizing people is one of the only ways you get those wide-scale programs moving. And so we need that same attention, and we need that same emphasis on getting people in the door for hepatitis C. So in thinking, finally, about what are the practical research operations, and how do you think about how can operational research support those lessons learned? We think of a couple of different things. We need some practical research that thinks about potentially what is, maybe not, and what is not optimal. How do you use some of the different models of care that currently exist? How do you use the ongoing DBS viral load options that are being studied for HIV? How do we integrate hepatitis C into those? How do we think about regimen and dose optimization? How do we do research for FDCs to make it easier on the patients, to reduce the pill burden? So in thinking about some of the various operational and practical research projects that have happened for HIV, we need to bring those to the HIV community, to the HCV community as well. So In conclusion, we have seen a lot of great accomplishments and failures in the fight against HIV. If we take a minute and learn from those, we will strongly position ourselves to rapidly expand and to develop access for hepatitis C. Thank you.